I think now it's open for discussion. In the chat box, I can't see any questions. But as an internist, sir, I would like to ask you that we are seeing a lot of these diabetic patients. I see more of diabetes patients, and most of these diabetic patients, especially the women, and in that age group of 55 to 65, most have an echo report of grade 1 diastolic dysfunction. Now, if we get a report of grade 1 diastolic dysfunction, how do you think one should proceed with a normal ejection fraction of, say, 55-60% and no wall motion abnormality? And this is a universal finding in the preventive echoes we do for these patients in a kind. So what should one do for this? And I mean, what is your thought process on this? Anybody can take, any of the panelists.
You know that we all know that HEPEP is a disease of elderly. It's a disease of the age and the aging process and the respective changes in the myocardium, as Dr. Panchuli has very beautifully highlighted. So in an asymptomatic patient, elderly patient with no other comorbidities, a grade 1 diastolic dysfunction with a normal E by E prime, I would take at normality at that age. I would report it because it is to be reported as grade 1 by definition, but it doesn't make any impact on the clinical outcome of that patient or the clinical management of that patient. But the same very patient has hypertension, has, let us say, diabetes of more than 20 years duration, and moderate CKD with an eGFR of 45, and is symptomatic with exertion of breathlessness. I would do an E by E prime on giving her a few, maybe a 6-minute walk test in the corridor and measure E by E prime again. And you will be surprised, sir, that E by E prime becomes almost double in these patients by just 6-minute walk test. And you do their NT-proBNP, they will be borderline because this patient only has exertional symptoms. There will be borderline elevated E by E prime. And then I will do probably a detailed echo, left atrial volume index, left atrial strain. Dr. Vinod Vijan will agree with me. Left atrial reservoir strain, and will then diagnose HEPEP in this patient and then move accordingly. Thank you.
May I add one thing here? Can I, with your permission, sir?
Yes.
That what Dr. Ponde has very correctly said, and even fortunately, Dr. Parashar sir is also here. He's one of the pioneers in diastolic heart failure he'll be talking on. In our routine measurements, today we just don't do a routine just by E by E prime. Sometimes we do make them walk or even do a hand grip test. Suppose a patient has got osteoarthritis, elderly person, that can also reveal. More importantly, in all our cases, we mentioned the left atrial volume index, which is calculated so accurately. We also do the LA-GLS. See the LA and LA ejection fraction. LA ejection fraction cutoff value is 35%. LA-GLS is 33%. And we have seen many patients, everything seems to be normal except for a diastolic dysfunction. People say, is it age related? But if we find that the LA-GLS is reduced, volume index is that, though these are not coming to guidelines, but they are very useful. We also, of course, mentioned the RVF and RVGLS also. So these
Can I give one comment?
Yes,
Rather
sir.
than going in various forms of exercise, it has been shown conclusively by raising the legs to about 60 degrees for 3 minutes, shifts about 200 to 300 ml blood, increasing preload. And there are a lot of studies that only this exercise may give you a lot of more information, especially LA strain, both at rest and after a LA leg lifting, those who cannot exercise. So there's a lot of very conclusive papers on this leg raising exercise.
Sir, my second query is that those patients who show these are the nuances of good echocardiographists. Now, the patient comes to the OPD, he has a grade 1 diastolic dysfunction. This patient is obese, he is diabetic, slightly breathless. You don't know because of deconditioning or because of his diastolic dysfunction. He doesn't have much edema or anything. There's a lady around 60. Do you think it is a strong indication to put them on SGLT2 because they are already diabetic? We are most of the patients putting them on SGLT2. But do you think instead of going into anything too detailed echocardiographic evaluation or a 6-minute walk test, a simple trial of SGLT2, which otherwise is also indicated in most of the patients, would this be an indication to grade 1 diastolic dysfunction in an obese diabetic who is somewhat moderately controlled, has some margin, would this drug come before the other drugs?
Sir,
I mean, will they take preference?
yeah,
The answer was already
obese
given by Dr. Ponde. Yeah, because if you start, you take patients more than 45, 50. At least we see 80-90% patients showing a diastolic dysfunction. That is one of the normal aging process. But as Dr. Ponde said, they have to be correlated with symptoms and if need be by E or E prime ratio, but not that if you find a grade 1 diastolic dysfunction, you start a high-flown therapy. Rest, I think Ponde can answer what he wants. So I think we should avoid that important drug in grade 1.
I think, sir, we have to look at the
and one of the
parameters.
biggest indications for a diastolic, and one of the biggest indications for a diastolic stress echo is a grade 1 diastolic dysfunction with symptoms. That is one of the important diagnostic indications.
Sir, what
I have one
in my
question.
practice, what we do in our practice is that we do a baseline. Doing a baseline is much cheaper than putting them on a costly drug for an indefinite period. If any such patient comes with grade 1 diastolic dysfunction, is diabetic, obese, they have usually sleep apnea, I would do the baseline parameters, put them on empagliflozin or even DAPA, and then when they come for a follow-up, I mean, we see for improvement. That would be much better.
I have one question.
Thank you, sir.
We have spoken so much about the preserved ejection fraction, the newer concept, the newer drugs also. So what will be the incidence of the arrhythmias in heart, that is heart failure with preserved ejection fraction, whether it's atrial fibrillation, atrial arrhythmias or ventricular arrhythmias? Are we have of late, Dr. Ponde, have you seen that so much of advancement with empagliflozin, so many drug dapagliflozin, SGLT2 receptors, have you postponed the ICD procedures or they have been deferred off long and efficacy of the newer drug have come on the way, and you are off late, you are coming to know that the device procedures have been deferred and the incidence has come down?
Madam, in the patients with heart failure with reduced ejection fraction, the global data, there are 3 registries. One is NASPI registry. The second is the European atrial fibrillation registry called Orbita. They are all shown that after the advent of ARNI, which improves the ejection fraction by almost 10-12 points. So many people were earlier on the waiting list of transplant or on the waiting list of ICD and CRT have been taken up after 6 months of therapy. So now the ESC guideline is very clear that before you implant a CRT or an ICD, a minimum 6 months very aggressive guideline directed medical therapy must be attempted. The ejection fraction to be reassessed, and if it is still below 30%, 30 to 35%, then only these candidates. Even in India, a lot of device companies will vouch by this, that the CRT implants and the ICD implants last 4 years after ARNI and SGLT2 use has increased, have remarkably come down. So that's what you are saying. But that is in HEPREF.
It is so difficult. Is it so difficult to calculate ejection fraction in a patient of atrial fibrillation because of variable complexity, unless you do a good 3D echo and various other things also? Very difficult to find out the precise ejection fraction in atrial fibrillation.
With this, I think we'll end this session. And I request thank very much. All the good speakers have spoken very well.
Thank you, sir.
A big applause for them. All the
Dr.
speakers.
Pancholia, thank you, sir.
And thank you very much.
Dr. Parashar,
and
sir.
I hand over the session to Dr. Mahapatra to continue with the next session. Thank you very much,
sir.
Dr. Mahapatra.
Thank you all. Thank you. Thank you all.
Thank you, Chairperson Dr. Asa Murthy, Dr. Sandeep Rai, and the eminent speakers, Dr. Sadanand Sethi, Dr. C.K. Ponde, Dr. Binod Bijan, and Dr. A.K. Pancholia.